far as bipolar disorder, speaking of that, yeah, sure, angry, irritable mood is one of the criteria. But what this study, this Joe Biederman and his group in Boston, that it looks like it's a combination of the irritable mood and also the high rates of comorbidity in bipolar disorder. So again, we can't really tease that out very well just from the mood disturbance itself. And then I think Dr. Tobin's going to talk a little bit about this as well. But severe mood dysregulation, and Dr. Tandon mentioned about this yesterday, that it's going to be included, some form of this is going to be in the DSM-5. And we're trying to distinguish, okay, what's true bipolar disorder? And by definition, we're talking about cyclic disturbances with intervening normal mood, whereas with these kids, it seems like they're always angry, they're always irritable, they don't really meet criteria for mania or hypomania. They are hyper-aroused, so it's not that they have decreased need for sleep, but they just can't sleep, and also that they're highly reactive to environmental stressors, sometimes very, very insignificant ones. So lifetime prevalence, this is older kids and adults, 3% in the population, mostly Caucasian males. Again, lots of comorbidity, which might make us think that, well, gee, what if this really is bipolar disorder? But the reactivity is very, very frequent, a lot of tantrums and rages and that sort of thing. So as has been pointed out in the discussion of including this in the DSM-5, is that a lot of the kids that are being diagnosed with bipolar disorder are probably more rightly to be considered in this category. All right, anxiety. When we think of aggression and anger discontrol, we think of mood disorders, but certain anxiety disorders can also be associated with anger and aggression. And nobody's really sure why that is. There could be some comorbidity issues or whatever, but we do know from a psychological point of view that anxiety and fear are very closely related to each other. And one of the things about being afraid is that you're either going to run or you're going to fight. So looking at PTSD, kids who actually have been traumatized, we know that that the hyperarousal, again, feeling like you're going to be hurt, is probably the thing that contributes mostly, or at least predominantly, to the aggression. And PTSD can also be misdiagnosed as bipolar disorder, and have seen a couple kids over the years who were able to make that distinction. And then the other thing is that new onset aggressive behavior in young children. One of the things to think about in the differential is a new traumatic event, and that's how they're reacting to it. All right, panic disorder. It took us a long time to figure out that younger people can actually have real panic attacks and real panic disorder. So some of the research on kids has lagged a little bit, but what we're finding out now is that, at least we extrapolate from the adult literature, is that there is anger in the anxiety disorders. But if you look at weeding out comorbid depression, that's really only panic disorder, not OCD, not social phobia, that's highly related to aggressive acting out behavior. So again, when we think about differential, we have to think about PTSD and we have to think about panic disorder. All right, psychosis. Just like with our adult patients, younger people who are psychotic have high rates of aggression. And you can see here that over 40% of patients were aggressive, and over a quarter had actually used a weapon or been assaulted towards another person. And again, we can think of reasons for that. Just generalized paranoia, command hallucinations, some combination of those symptoms. And this is a fairly recent study here from down under. The other thing is that whether it exacerbates the problem of aggression, whether it may initiate the process of aggression, that cannabis use is also associated with that, and also behavioral disinhibition in general, and also younger ages rather than older ages. So these are all additional risk factors in the presence of psychosis that tends to increase the chances of aggression. As far as tics, and Dr. Murphy's going to talk about this, I'm sure, that there's lots of psychiatric comorbidity in the tic disorders, especially with Tourette's syndrome. And the rage attacks of Tourette's are really kind of famous. And really, when you look at all of the symptoms in this complex, this seems to be the thing that impairs people more than anything else. So more than the tics themselves, more than the associated OC symptoms, more than the associated ADHD, that it's really the anger and aggression that tends to cause a lot of impairments, both psychosocially, academically, as far as self-esteem and that sort of thing. Intermittent explosive disorder. The numbers are higher than we used to think that they are, or that they were. And I think this is really underdiagnosed. Some of the kids that I've seen over the years that have been diagnosed with bipolar disorder with lots of anger and aggression really met criteria for IED after we ruled everything else out. Point prevalence in one study, Sue McElroy's, is 2.37%. Lifetime prevalence over 6%. And this is in the community. So how about clinical samples? Probably higher. And if you look at the adults, and this is her study again, this is an older study now, but when she went back and looked at the adults with IED, when did the problems start? Sometime early in adolescence. So yeah, we are seeing these kids and perhaps we're not recognizing this problem. Just real quickly, as far as personality disorders, a lot of talk recent years about the callous, unemotional traits. You know, where people will be hurtful towards other people and they seemingly don't care. These folks have very stable patterns of aggression. And when we look at the kids with the CU traits, they look a lot like psychopathic adults, you know, really hardcore antisocial adults. As far as borderline pathology, now this was in adults, but almost 3/4 of them engaged in some kind of violence within the year's time of study. And a lot of them had antisocial characteristics. Not surprisingly, the trigger for a lot of this was interpersonal conflict. And the variance was actually shared, so that if you just had borderline personality alone, it was less predictive than if you had some antisocial traits along with it. So again, we know that there are a lot of overlaps within clusters, within the DSM, as far as personality disorders. So the borderline stuff is really obvious a lot of the time with the self-injurious behavior and that sort of thing. But if we look a little closer, some of these folks may have antisocial features. And can we diagnose borderline pathology in younger people? Absolutely. And this is something also that I think is probably underdiagnosed because we're afraid to label them, and yet we're not going to identify it accurately and institute more appropriate treatment. As far as other personality disorders are concerned, this is an epidemiological survey that was done, and what they wanted to look at was violence among individuals that either had pure strain psych conditions, comorbidity, and looking also at the breakdown of very specific psychiatric disorders. So I'm just going to kind of go through this real quickly. They did leave out antisocial because violence was part of the diagnostic criteria. They did not explain why borderline pathology was left out. So when they control for various different kinds of other factors and comorbidity, they looked at violent behavior both before and after age 15, and it was higher in people that had paranoid, schizoid, histrionic, and OC personality disorders. And when they looked at comorbidity, the rates of violent behavior, again with either before or after that age 15 cutoff, were greatest for paranoid and histrionic personality disorder related to the other ones. So these numbers right here are before age 15, after age 15. You can see at age 15 and above, the numbers basically double and triple. Okay, real quickly about the developmental disorders. In general, across the board, intellectual disabilities have higher rates of aggression. So for example, the disruptive behavior disorders, 25% versus a little over 4% in those that did not have intellectual disabilities. If you look at the ASDs, we have half of them showing aggression versus only 10%. This is Matson's group down in Louisiana. Fetal alcohol syndrome, when they broke it down to quote-unquote anger problems,